So we are going to go.
It's recording.
We're good, right?
Yeah, you're recording. Okay.
Sweet. I think we are good to go, guys. So let's go ahead and get started. I'm going to do a little introduction first, and then we're going to hand it over to Lauren, our myofunctional therapist, who is going to give a great presentation today on everything myofunctional therapy. So this is session 6 of our 10-part free CE lecture series to providers. Just want to take a few seconds to say thank you to everybody who has come out to learn up until this point. I think the first 5 lectures have been wonderful. We still have 4 more to go, which I'm really excited about. So today, obviously, we have Lauren Reinholt. She is myofunctional therapy. Next Tuesday and next Thursday, we have a good friend of mine, Dr. Vinay Hasmani, who's going to talk about heart health and some cardiovascular complications to look for within the dental office. On Thursday, we are going to have another good friend of mine, Dr. Doug Adams, a physical therapist, talk about how to let exercise be your stress relief. And then the 2 last lectures that we have for this series are on tongue ties on Tuesday, May the 19th, featuring Dr. Joanna Green, as well as Lauren again and myself. And then finally, we wrap things up with Lauren's last lecture, which will be on Thursday, May 21st, and that is going to be on the oxygen advantage and the proper and the power of proper breathing. So really excited for those. For any of you who have been on or would like access to our previous lectures, you can find all of these located on either our Facebook page or our YouTube page. Also want to welcome anybody to follow us on social media. We typically do a lot of fun stuff within the office and produce a lot of good original content, as well as share anybody else's content from around the world that we think is valuable to our patients and to our followers. So take a minute to take a picture of this slide and make sure you follow us on social media. So not to take up too much of Lauren's time, because like myself, Lauren can get going and then she runs over. So we're going to try and keep you guys on time today. So I just wanted to give a quick little intro on Lauren. So as you all know from my previous lectures, Lauren was a former dental hygienist with me in our general practice. And so Lauren had a great following. She was really good at what she did. The patients were very sad to see her leave. But, just like me, she left for a passion, and she left for a cause that she feels is her life mission. And so she moved over with me to the Pain and Sleep Therapy Center. And she has gotten a lot of her advanced education through courses after school and after she was practicing dental hygiene for a while. And so I'll let her kind of tell you about her background, but I just wanted to take the moment to introduce her. She is such a great resource for me within my center here. We communicate on patients just about every day. She works with a lot of my treatment plans and things. And I actually published an article back in the Orofacial Myology News last year, and they had asked me to write about a topic, and I had written about how myofunctional therapy was like the missing link in my pain and sleep practice. And I truly do believe that we were offering patients great service here with their jaw pain, with their TMD issues, and with their sleep issues. But it really wasn't until Lauren's program came to fruition and came to be the powerhouse that it is today that we were getting, ultimate resolution of not just the chief complaints, but really a pattern of long-term success for a lot of our patients that come in here. So I really do credit myofunctional therapy with a lot of what we do here at the center. And I can honestly say just about everybody that walks in the door can benefit from this therapy. So I'm looking forward to hearing what Lauren has prepared for us today. So without further ado, I am going to stop my share. And Lauren, if you don't mind, can you go ahead and take over?
You see?
Can't see your screen share.
Okay.
Oh, you know what? Let me make you.
I think that it says, yeah, you have to do something.
Yeah. How about now?
Okay. Yep. I'm good.
Awesome.
All right. Can you see it now?
Yeah, we're good. Rock and roll.
Okay. Awesome. Okay. So my name is Lauren, and I work at the Pain and Sleep Therapy Center located in Delaware, where we specialize in TMJ dysfunctions and sleep breathing disorders in both adults and children. So I was the dental hygienist for 15 years prior to becoming an orofacial myofunctional therapist and a Buteyko educator. I had the pleasure of training with Sandra Holtzman, who is a part of the International Association of Orofacial Myology, Dr. Stephen Olmos, Crystal Robinson, Patrick McEwen, and I also had training through the Myofunctional Research Company for MyoBrace. So, what exactly is orofacial myofunctional therapy? So, first off, I just want to say that you're going to hear many different terms. You may hear myofunctional therapy, you might hear orofacial myofunctional therapy, you may hear orofacial myology and facial myology. So, it's all the same thing. Today, I'm going to be kind of using the terms orofacial myofunctional therapy, which is abbreviated as OMT, and myofunctional therapy. So what exactly is myofunctional therapy? Myofunctional therapy is an exercise-based therapy. So just like physical therapy that is training the body back to optimal shape after sustaining an injury, myofunctional therapy helps by training the soft tissues of the face, the neck, and the mouth to function at the height of their ability. So I work with people who have a broad range of concerns, whether that be mouth breathing concerns, sleep breathing concerns, people who snore, have sleep apnea, digestive issues, crooked teeth, and tongue ties. So is this new? So believe it or not, myofunctional therapy actually dates back to the 1900s, to be exact, 1907. The exercises used to reposition the tongue, habituate nasal breathing, and correct swallowing became known as myofunctional therapy for the first time in 1948. So it actually has been around for quite some time. So what are the goals of therapy? What are we trying to establish here? We're trying to establish a lip seal, nasal breathing, proper tongue posture, and a correct swallow pattern. So today I'm going to really be focusing in on all of these goals a little bit more further in detail with that. So what are the benefits of doing myofunctional therapy? So of course, airway development is one of the best benefits, where really airway trumps all. We're guiding healthy craniofacial growth. We're correcting any soft tissue dysfunctions, identifying the need and referring for speech therapy. So really, we try to work with a whole team approach, stabilizing the teeth before and after orthodontic treatment, and then replacing any old dysfunctional habits with healthy functional patterns. So one of the goals of myofunctional therapy is nasal breathing, and nasal breathing is so important. We should always be breathing through the nose in the morning, like all day long, and at nighttime. When we breathe through the nose, we're breathing in warm, moist, filtered air. So imagine your nose as a Brita filter. It's filtering all of that bacteria out of the nose. We're also getting the benefits of nitric oxide. So nitric oxide helps to regulate our blood pressure, it reduces cholesterol, and it supports a strong immune system. In addition, you're getting increased oxygen delivery. So mouth breathing is actually associated with a fight or flight response, which is the sympathetic response. And when we are nasal breathing, we're in a parasympathetic state. So we're in that rest and digest state. And we're engaging the diaphragmatic muscle. So if everyone right now were to take their hands and put them around their ribs with the lips closed and taking a breath in through the nose and out through the nose, you're going to feel that muscle expanding inward and outward. And as that muscle expands in and out, it helps to massage the intestines that also aid with digestion. In addition, when we're teaching nasal breathing, as we're also teaching proper posture, which is we want the shoulders back, having the shoulders, we want the head aligned with the shoulders. And we also kind of want to imagine a string pulling you from the crown of your head. So one thing I want everyone to do right now is to kind of just take a look down at your chest and just take a breath right now out through your mouth. And what do you see? So you're going to see upper chest movement. You're going to see the shoulders may rise. So mouth breathing is activating that chest breathing. So right now, if everyone were to take one hand on your chest and put one hand on your tummy, like right above your belly button, with your feet flat on the floor and kind of shoulders back, imagining that string pulling you from the crown of your head, taking a small breath in through the nose and then allowing that relaxed breath out, really focusing in on the colder air coming into the nose and then that warmer air exiting the nose. So this exercise really works on slowing the breathing down as well as engaging that diaphragmatic muscle, which is what we want. So that breathing is going to be soft, slow, smooth, and effortless. We actually were born to be belly breathers. So where is your tongue? So I want everyone to kind of freeze right now, and I want you to think about, where is the tip of your tongue resting? Where is the dorsum, the back of the tongue, resting? You know, are your lips open? Are they closed? Are you nasal breathing or mouth breathing? Are you using the chest or the diaphragm? So when you have one hand on your chest and one on your belly, what hand moved first? So a correct, healthy resting posture, or we want the lips closed. The lips are our body's natural braces. We want to be nasal breathing, as I talked about the benefits of that. The teeth should be slightly parted, what we call a freeway space, so about 2 to 3 millimeters of that parted teeth there. We want the tip of the tongue to the tail of the tongue resting up to the roof of the mouth, because our tongue is nature's palatal expander. So a proper tongue posture is that whole tongue sitting on the roof of the mouth. So for all of you dental professionals who are on here that know what the incisive papilla is, that is what we call the spat. So that is where the tip of the tongue should be resting. But for those of you on here that are listening that don't know that term, the incisive papilla, the spat, is actually, if you take your tongue on right behind your front teeth and you wiggle it back and forth, you're going to feel a speed bump up there. So that is where the tip of the tongue should be resting. It should never be pushing against the teeth. And another tip is typically any N words like Nancy, noise. That is where the tongue should be resting. So an unhealthy resting posture is mouth breathing. So as I talked about earlier, when we breathe through the nose, you know, we're in that parasympathetic state. But when we're breathing through the mouth, we're in that sympathetic, that fight or flight state. And we're also breathing in dirty, unfiltered air that causes inflammation on the lymphatic tissues, which, you know, those are the tonsils and adenoids. So they become the first line of defense. And as they get larger because of that, they start to occupy space within the airway. And then, of course, the lips are going to be parted. So a lot of people think with mouth breathing that the lips have to be significantly parted. Even just slightly parted lips is considered mouth breathing. The teeth are going to be clenched or abnormally far apart. You're going to have a low resting tongue posture to the floor of the mouth. The lips will be strained to really get them closed around the teeth. Your profile may be what we call retrognathia. So that is where that lower jaw is set back. The face will be long and narrow, which also can be known as adenoid face as well. Flattened cheekbones, which we call mid-face deficiency. The mentalis muscle here will be bunched, and you'll have a forward head posture, which is very common with people who mouth breathe, who are tongue-tied. And one thing to note with forward head posture is that every inch forward is actually 10 to 12 pounds of added pressure on the spine. So I wanted to show this here. I don't know. Can everyone see all these pictures there? So this is actually a 5-year-old boy who is a mouth breather 100% of the time. So I wanted to show this because the one slide here shows the CBCT scan that we use in the office. And you can see how his lower jaw is set back. So he has a very retrognathia profile. He really struggled to get the lips closed around the teeth. And as we know, the lips are nature's braces. So you can see how he has significant flaring of those anterior teeth. The gums are very red and inflamed. And because of his mouth breathing, that low resting tongue posture, he is going to have, you can see his high palatal vault. So if you were to look at him, you might see, oh, he has pretty good spacing up there, but his palate is very narrow. And one thing to note is that the roof of the mouth is actually the floor of the nasal cavity. So anytime you see that high palatal vault, it's very common to see that with people who have deviated septums as well. So why does oral rest posture even matter? It matters because our genes tell bone how to grow, but the muscles are telling the bone where to grow. So therefore, most malocclusions are not a genetic issue, but rather a muscle issue. So if the muscles are not working as they should, the bones are not going to grow to their full genetic potential. So this is a sea turtle that you can clearly see it got a plastic soda can holder wrapped around its shell. And as you can see, the shell conformed to this plastic soda can holder. So if the muscles are not working as they should, then the bones will conform to these soft tissue dysfunctions. So proper resting of the tongue is essential for growth and development because by age 2, we have a mature swallow is established. And 3, we have an adult-like swallow that is established. So if a child is, say, their mouth breathing, they have prolonged pacifier use, sucking of the fingers, the thumbs until they're 6 or 7, that's going to interfere with their swallowing reflex. And by 3, we have that adult swallow is already starting to be developed. By age 6, 80% of our upper and lower jaw is completely done growing. And by 12, 90% of the upper and lower jaw is completely done growing. So that window of opportunity is really short. So it is crucial we are screening all of our patients, especially at a young age. Okay, so I want to show this video here of a correct swallow pattern. So typically with a correct swallow pattern, you're going to have, the tongue is going to go up and kind of back like a wave, okay? So you're not going to have any head bobbing. The shoulders are not going to rise. You're not going to see compensation in like neck muscles and anywhere else. So I'm just going to show this real quick here.
The normal swallow is not spectacular. The lips are together at rest with minimal activity. The mandible moves slightly upwards as the teeth contact. The tongue tip moves up against the premaxilla, followed by the body of the tongue pushing against the maxilla. This creates the correct arch form and good dental alignment. There is minimal compression of the TM joint.
Okay, so an improper swallow pattern is actually that reverse of the proper swallow pattern. So some people might know that as the anterior tongue thrust, or a posterior, which is unilateral or maybe bilateral on both sides. You will see compensations in other muscles. So you could see compensations in the neck. You may see like the lips and that mentalis muscle move upward, the cheeks moving forward. So kind of what we call like a facial grimace, like we're using all of these muscles to kind of get that swallow back. One thing to point out too is if you're cleaning someone's teeth and you notice they have a lot of wrinkles up here on the upper lip, and they're not a smoker, that could be what we call pursed lip swallow. So they're really compensating using other muscles. So I'm going to show a video here on this swallow pattern as well.
The reverse swallow starts with the lips opened and much activity from the lower lip and mentalis area. The teeth are not together and usually separated by the tongue. The mandible is moved backwards during the reverse swallow. The tongue tip moves down and forward between the teeth. The tongue body moves down and away from the maxilla. Note the backward movement of the mandible. The action of the tongue distorts the upper arch. The tongue moves between the anterior teeth, causing lower crowding and class 2 malocclusion. The TM joint is compressed as the condyle is moved back during each and every swallow.
Okay, so one thing I wanted to point out too is that with an improper swallow pattern, every time that we're swallowing with a forward, we're not able to also clear the eustachian tubes. So you might see an increase with ear infections or a history of past or present tubes in the ears. So the only way we can clear the eustachian tubes is with that up and back, that correct swallow pattern. Another thing, as they talked about in the video, is orthorelapse as well is very common. And then of course you may see people that even have like that gagging reflux as well. So that could also be an indication of a swallowing issue, as well as poor muscle tone in that tongue. Okay, so just remember, tongue thrust is actually a symptom of a much larger issue, and that issue is improper oral rest posture. So let's jump in and discuss OMDs. So what are OMDs? OMDs are disorders of the muscles and the functions of the face and the mouth. So they can cause a variety of effects, whether that be directly or indirectly, from problems with breastfeeding, stunted facial growth, disordered chewing, swallowing, speech impediments, TMJ disorders, poor oral hygiene, malocclusion, stability of orthodontic treatment, and overall facial appearance. So again, what are we looking for? It's anything that is indicating a myofunctional impairment. So anything that is impairing the 4 goals. So does everyone remember the 4 goals we've talked about? We want a good lip seal. We want to be nasal breathing. We want a proper tongue posture and a correct swallow pattern. So the common link in OMDs is the position of the tongue at rest. So there are 3 main common OMD contributors, and those are airway issues, oral habits, ankyloglossia, which is tongue tie. And I'm going to kind of go into all of these main contributors. So the first one is airway issues. So of course, if we have chronic nasal allergies, rhinitis, allergies especially contributed with the mouth breathing are the 3 Ds, and that is dust, dairy, and dander. Nasal restrictions, so that could be a deviated septum, nasal polyps, bone spurs, hypertrophic turbinates, maybe a nasal valve collapse, enlarged tonsils and adenoids. So if you have that restriction up here, what's going to happen is that you're going to develop a habit of mouth breathing. And once that sets in, that's there for life. So that's going to cause the tongue to rest low. The lips are going to rest apart. That low resting tongue posture continues to narrow the palate and crowd the teeth. So you may see as you clean people's teeth as well, as those of you that are in the dental field, you may see some premolars extracted as well. So that is another clue of that very narrow palate. As that palate continues to narrow, you're going to see that high palatal vault, which again, it impinges on the nasal cavity. So as I mentioned before, the roof of the palate is the floor of the nasal cavity. So it's very common to see those high palatal vaults in people who have deviated septums. And then as that tongue continues to rest low and everything is narrowing, the airway is going to develop narrow as well. So I use the analogy of kind of breathing out of a coffee straw to a really small airway. And then of course, if the tongue is up, the tongue is going to stimulate the jaws. It's going to stabilize the jaw. It's going to have everything develop nice and wide. Remember, the lips closed are going to have the teeth coming straight. The tongue up is going to create that nice width. It's the body's natural palatal expander. And then in addition, the airway is going to develop nice and wide as well. So again, imagining breathing out of a large milkshake straw. That's how I kind of describe that large airway. So how big is your airway? Most people do not know how big their airway is unless they've had a CBCT scan. So this is a scan that we use in our office that really assesses the width of the airway, the width of the palate, and looking in the nasal cavity as well for any kind of restrictions that may be going on. So, imagining that airway A, as I talked about before, is breathing out of that coffee straw. It's very narrow. And then B is breathing out of that large milkshake straw. So ask yourself, what airway do you want? Do you want airway A or B? I know me personally, I want airway B. So, people ask me all of the time when they're in for consultations, like, how did this happen? How did I develop this small airway? So it isn't something that happens overnight. It is something that we grow into. So remember, poor airway equals poor development. The jaws grow at night. So it is crucial, especially for kids, that we have their lips closed, that they're breathing out of the nose, the tongue is resting to the roof of the mouth, because it's going to have to stimulate the jaw to grow in the right direction. And then remember, if the tongue is up, it's going to support a strong, tense airway, which is what we want. If the tongue is down low, it's more likely to go back and close off that airway, which is what we do not want. So one of the other common OMD contributors are oral habits. So these are like physical conditioners that are creating that low resting tongue posture. So the big thing is asking the intensity of how often the frequency of how often this is happening, the duration, maybe what's triggering this. So anytime we have these oral habits, it is impairing the suckling, the swallowing, the chewing, the breathing reflexes. So, pacifier use, prolonged sucking on the fingers, it could be the thumb or both fingers, even sucking on a blanket, a stuffed animal. So that will create an open bite. Also, cross bites are pretty common as well. And then sippy cups is another one. So I typically, when I would see my patients in the dental office setting, I would always ask about oral habits, and especially when a child comes in for their first appointment, asking about sippy cups as well, encouraging a cup with a straw, encouraging the 360 cups. Nail biting. Nail biting can cause TMD issues. Lip biting, licking of the lips. All of these are all signs of like these oral habits. So, and then the other common OMD is ankyloglossia, which is a tongue tie. So we all have a lingual frenum that runs underneath the tongue, and that connects to the floor of the mouth. So for some people, it is restricted. A tongue tie is known as a restricted lingual frenum and sometimes tethered oral tissue, as abbreviated as TOT. So it prevents the tongue from resting on the palate, which is where we want it, because again, it stimulates that maxillary development. It can impair craniofacial growth. So if the tongue is not up, the face will develop long and narrow. We'll have crowded teeth, a weak chin, TMJ issues. Breathing can be impaired. So one thing to mention about that is that if the nose is not being used, we are breathing out of the mouth, and the nose gets more congested. So it's kind of like that vicious cycle that goes round and round on a merry-go-round. And then mucus is unable to drain. So it's going to collect in the turbinates. It's going to collect in the maxillary sinuses. The less the nose is used, the more congested it actually gets. So we want to use the nose for breathing. Sleep can be impaired, increased risk of developing sleep apnea. So research shows that tongue ties increase the risk of developing sleep apnea and airway issues. It can lead to chronic jaw pain, facial pain. Posture can be impaired. So one thing with that too is that we have fascia that runs under the tongue, and it connects to the muscles and tissues in the body. So one tight muscle, that tight restricted frenum there, can actually create tension in another part of the body that is seemingly unrelated to that one area. So, and one thing to mention too is that when assessing tongue tie, always consider function above appearance. If the tongue ties are left untreated, abnormal tongue function is occurring early in life. That is affecting the suckling reflex, the swallowing reflex, the breathing reflex. Okay, so ankyloglossia and lip tie. So just a few things to go over when checking for this, like in the dental setting. So of course, family history, typically asking like, does the mother, does the father tongue tie? It is an inherited trait, so genetic mutation. Are there feeding issues? So with mom, some of the feeding issues could be difficulty with breastfeeding, that suction is unable to be achieved. There might be low milk supply, plugged ducts. For the baby, they might be unable to latch, unable to hold a pacifier or a bottle. They may have poor weight gain. They may pop off of the breast frequently, gasping for air. And then they may have excessive drooling or even bite the breast. And then of course, digestive issues. So colic, acid reflux. Another one, especially even with older patients who have tongue ties as well, is having excessive belching, bloating, gassy, hiccups. All of that is occurring because they're swallowing too much air because of that mouth breathing. And then it requires a lot of effort for eating. So one thing to point out with tongue ties is that they do more of a munching motion as well. We want to make sure we're lateralizing when we're chewing. So we're rotating side to side as we chew. So people who are tongue tied have a difficult time doing that, creating that bolus as well. And then another thing is they may pack the food in of their cheeks, kind of like a chipmunk. There may be texture issues. So maybe they're avoiding certain foods. They stick to like a softer diet. Maybe it's chicken nuggets, applesauce, pudding. It's also common with those softer diets to see that with people who have maybe enlarged tonsils as well. They may use the fingers to poke food in the mouth. There may be speech issues, so inability to lateralize R's or L's. Very common with tongue ties. And then one thing as well is diastema. So, with the diastema, that's common with lip ties as well. If we have that tight labial restriction, that lip tie there, it can be associated with a short upper lip. That leads to a lack of that lip seal, which is what we want. And then therefore that can lead to malocclusion as well. And then of course that high narrow palate that I talked about previously. So, this is what we use in the office as well. It's called QTT, which is a quick tongue tie assessment. It is not a detailed assessment. So it is more of a red flag that you should look more deeply into the possibility of a restricted lingual frenum. So a normal range of motion when you are checking this is it should be about 45 to 65 for a max opening. Anything that's kind of 45 and under is common with people who have TMJ issues or maybe a limited max opening. So with this, what I recommend doing is you want to place the notch on the lower central incisors. And then you are going to have the patient open as wide as they comfortably can, measuring that and reporting that number. So as you can see here, this person's max opening was a 48. And then you're going to have the patient put their tongue on the spot, the incisive papilla. We don't want to see the tongue curl back. We want to just rest up there, and you're going to measure how wide that is. So with them on the tongue on spot. So this patient was a 33. Another thing that we do is measure the patient kind of sucking the tongue to the roof of the mouth. So that could be known in myofunctional therapy, we call the cave or the suction and hold. I will note on that too that most patients who do need myofunctional therapy really have a hard time suctioning the tongue flat to the palate. So with taking those two measurements that we talked about, like the tongue to spot measurement and then having the patient open as wide as they can, what you do is you want to divide that 33, which is that tongue to spot, to the 48. So the TRMR is 68%. So that would be on the grading system a grade 2. Okay. So TRMR is just a grading scale for a functional classification of ankyloglossia. So the higher the grade is, like the 3, the 4, it is going to reflect a decreased mobility and an increased severity of a tongue tie. So, really asking yourself, can the patient touch the incisive papilla without closing more than 50%? So this is more of a functional tongue tie assessment. So I feel like when I was practicing dental hygiene, this is a really good one, and just some tips and things that you can do with your patient. So, as you do your oral cancer screening, you're having the patient protrude their tongue out, you're checking the lateral sides of the tongue. So I used to have the patient, I would do it with the gauze and I would kind of move the tongue for them. But then when we started really looking for tongue ties, I started just kind of having the patient move their tongue themselves. And that is a good assessment in itself to see if there is some restriction there. So when you have the patient protrude the tongue out, the first thing you want to look for is on the top of the tongue. You want to look for any dimple or depression that may be on the tongue. So kind of on the 1/3 of the anterior of that tongue. Looking for that. It's very common with people with posterior ties to see that dimple or depression on the tongue. And then, of course, you want to kind of look to see if the patient can move their tongue from one corner of their mouth to the other. We want to have that lateralization. You want to look for making sure the tongue doesn't kind of dip down. Is it difficult for them to do this? Asking them that, like, how does this feel? How does the neck feel as you're kind of moving that tongue? So, and then as you're having them kind of check that, like I said, you want to make sure the tongue is not dipping down. Lateralization is really important to achieve, especially when we're chewing, we're forming that bolus as well. And then another thing to do is take your finger and you can touch the upper and lower posterior molars and see if the patient can touch those areas with their tongue. without moving the jaw. So that's a good indication to see if there's any kind of restriction. You may notice that a lot of people who are tongue-tied may build a lot of calculus, tartar buildup on those buccals of those posterior molars. They might have higher cavities as well, because our tongue is actually a cleaner. So we want to be able to reach those areas to clean them. Another thing you can do is have the patient take the tongue and touch the upper lip. So looking to make sure that that lip does not curl inward when the tongue touches that area. And then of course, is there difficulty with that? Another thing to check for is sucking the tongue against the palate. So it's what we call that suction and hold, that cave. And are they able to suction the tongue in that area? So basically having the patient maybe do a click slowly and then have them freeze before they release the tongue down. As I mentioned before, a lot of people who need myofunctional therapy really have a difficult time suctioning that tongue flat to the roof of the mouth. And then of course you want to look at the shape of the tongue. So you can look at that on protrusion. I find that it's best to see the shape of the tongue when it is elevated. So you'll really be able to see that heart shape. You might see a V shape. You might see a square shape or oblong shape of the tongue. And then, looking for the frenum attachment. Is that attachment short? We do have 2 points of attachment on the frenum. The one is to the floor of the mouth. So it'll either attach to the sublingual carbuncles, the alveolar ridge, or it may attach on the tongue. That's another point of contact. So it may attach on the middle of the tongue, middle to apex, or apex of the tongue as well. So these are just some quick assessments that you can do in the dental chair. Like as you're doing your oral cancer screening, I really recommend incorporating some of those to really check the function as well. So how to recognize OMDs in your practice. So the first step would really be to incorporate an airway evaluation in your practice. So if you're interested in obtaining a copy of what we use within the practice, feel free to email me directly or Dr. Robinson. This is what we give out to the parent to fill out at their routine hygiene appointment. So really up until the age of 15 is what we would have the parent fill this out for. And then of course, if they answer yes to any of these questions on here, these are things that are common, but they are not normal. So, this is just one section of this questionnaire that we use. So, is the mouth open? Of course, we know mouth breathing is not normal. Are the child snoring? Snoring is not normal. Snoring is that vibrate noise that occurs right before the airway collapses. Is there trouble breathing, a struggle to breathe? Do they stop breathing at night? Are they a restless sleeper? When breathing becomes difficult, it actually is manifesting itself in movement. Is the child wetting the bed? I can't tell you enough how many people that I see in the practice that come in and their kids are, 6, 7, 8 still wetting the bed. Sleep breathing disorders could be playing a role. The brain is working harder to release oxygen than it is to control bodily fluids like bladder control. Is there hyperactivity at nighttime? Another thing, it presents the same as insomnia for an adult. It's really that drive to stay awake because the brain knows something bad happens at night when it goes to sleep. And then other things is sweating. That really is that evidence the child is struggling to breathe at night. One thing I want to point out too is that you may have parents that are just not sure. They don't know what's going on at nighttime. So I really recommend having them observe. Observation is key. Going in there and checking on them at 3 different points during the night, recording them for 2 minutes at a time. When they first go to sleep, middle of the night, and then right upon awakening. We also gave out a private eye in the practice as well, which is just a little sheet with some key points of things to be on the lookout for. So it talks about when they're sleeping, when they're awake, while they're eating, just different key things like I said, that are common but are not normal. Okay, so then this is an adult airway questionnaire. So I really recommend incorporating these questions into your medical history. So, every 6 months, the patient is coming in for a routine prophy, and you're asking them anyway, have you been hospitalized? Have you had any surgeries? Are you taking any medications? Any new allergies? So why not ask them a few of these questions? I look at it this way. We really owe it to our patients to be evaluating the airway, because for some of our patients, we are the only healthcare providers that they may be seeing routinely. I can't tell you enough how many patients that I would see when I would clean someone's teeth and we would ask, like, when was your last physical? It's been 5 years, 6 years, 7 years that they haven't been going routinely. So if they're not getting evaluated, we may be the only healthcare providers that are seeing them routinely. So some of the questions to ask are, have you been told that you snore? Do you have a family history of sleep apnea? Do you feel you get a restful, productive sleep? Do you have a lack of energy upon wakening? Do you use medication for headache pain or as a sleeping aid? One thing to note on that is melatonin. A lot of people, I feel like, take melatonin. I had a lot of parents who would tell me they would give melatonin to their kids. So that is a clue too. I mean, we shouldn't really need those things to go to sleep. Do you experience sounds like clicking or popping of the jaw joints? So one thing to note on the clicking and popping, many people think that is just a minor inconvenience, but it can result in a lot of pain and discomfort down the road. Clicking and popping of the jaw only gets worse with time. Sleep breathing disorders and TMJ disorders they're really linked together. Okay, so this is a Malin-Patty score. So this is something that should be done with the patient sitting upright, having them stick their tongue out and saying ah, or don't have them say ah, that's what I meant to say. So typically a class 1 is that if you have the patient stick their tongue out, you should be able to see the soft palate, the uvula. And then a class 4 is they stick it out and you can't see the soft palate. You cannot see the uvula. So a class 3 and a class 4, typically it's simply easier for the patient's airway to be blocked by tissue when they're sleeping, resulting in OSA. So if you see a patient who has this airway classification of the 3 or the 4, and they're telling you they snore, they feel unrefreshed upon the morning, I would definitely suggest they have further evaluation. One thing to note with these, I would recommend even laminating a copy of this and putting it out in your operatory rooms, especially until a lot of your staff gets used to this without having to reference to it. The tonsil grade is another one that I think is great to have in all the operatory rooms as well. So making a laminated copy of this. So obviously with 1, that is where the tonsils are actually hidden within the tonsil pillars. And then 4, it's extending into the midline. So they're kissing. So, you may have a parent that fills out the airway evaluation and they're answering that their child snores, they have restless sleep, wetting the bed, and then you observe that their tonsil grade is a 4. So, at that point, I would definitely recommend that they have further evaluation. And one good thing to point out on this too is that, it's good to check this every 6 months, because you may have that parent that says, you know what, you're telling them that their child's tonsils are a 3 or maybe a 4, and they're like, well, they're just getting over a cold. It's good to monitor that and check that as well, and put that in the chart that, oh, at this visit, Johnny had tonsil grade 3, we see him back in 6 months and it's still the same. At that point, then you can kind of talk to the parents about it. So it's good to have documentation and be tracking this every 6 months as well. Okay, so evaluating the rest and tongue posture. So one of the things that when you're kind of going out to the waiting room, you're grabbing your patient to bring them back for their hygiene appointment, is really observing the patient as you're walking them back, checking their posture, their profile. The head follows the tongue. So if the tongue is resting low, that head posture is going to be forward. Forward head posture is truly an adaptation of the body to open the airway. And then checking to see, are the lips open? Is the patient a mouth breather? Other signs to look out for with the mouth breathing are dry chapped lips. Are the gums red, inflamed? Are the gums bleeding? Gingivitis, periodontal disease. That is one other thing too that I found when I was treating people who were going through periodontal therapy. We would do the deeper cleaning and then to still see them having the bleeding, doing everything they can at home, all because they were mouth breathing. So they had something else underlying going on. And then of course, looking for bad breath is another one. The dry mouth increases the rate of cavities as well. And then of course, that tongue is resting low and forward. So another good thing to do is evaluate the swallow. So I did this a lot with my kid patients that I would have, is that, I would, to check their swallow, I would have them sitting upright, and I would take the air water syringe and I would squirt a little bit of water into their mouth. And then I would ask them to hold that water. And then I would take my fingers and I would pull their cheeks out and I would have them swallow. So looking for, are you seeing the tongue come through the teeth? Do you see saliva or water coming through the teeth? You're looking for that thrusting, that anterior, maybe the posterior, looking for a sign of that muscle strain. So do they have to compensate and use all these muscles? Do they have to bring the cheeks forward? Do they have to bring the lips and mentalis muscle upward? And then, of course, show this to the parents as well, the way that they're swallowing. I think it's great to let the parents know what you're observing as well. And of course, stressing all of the reasons why, we want that correct swallow pattern. And of course, how this contributes to orthodontic relapse. So, and then evaluating the occlusion. So, you want to evaluate open bite, which can also be caused by oral habits such as finger sucking and pacifier use, mouth breathing, overjet. That is where that lower jaw is underdeveloped. It's kind of set back there. That's that retrognathia profile. One thing to take note on that too is snoring and sleep apnea are not uncommon to see with a retrognathia profile. With that, when it's set back, that jaw, that tongue is likely to fall back and kind of close that airway off. Other things to look out for are the deep bites. So kind of the last picture up here that I have, most common causes that small lower jaw. Low tongue can also cause a deep bite. Oral habits such as nail biting can contribute. Clenching and grinding can deepen the bite as well. And then of course, deep bite can also contribute to sleep apnea. And with a lot of these occlusions, they can affect speech as well. It may be unclear, chewing, swallowing are affected. Another one is the underbite. So that is a class 3 occlusion. And that is where the lower jaw is actually larger than that upper jaw. And also, that low resting tongue posture could be a contributing factor as well. Crossbite, bilateral or unilateral. The gummy smile, be on the lookout for that as well. That is insufficient jaw growth of the mandible, that lower jaw. And then the upper jaw just keeps growing down too far. The crowded teeth, that high narrow palate as well. Other things to be on the lookout for are clenching and grinding. So we know clenching and grinding is kind of that body's way of pushing that lower jaw forward to open everything up. And it can be a sign of any kind of restriction of airflow, whether that be in the nose or the airway. Signs you may look out for in the dental office are the scalloping of the tongue, attrition, abfractions, mandibular tori, large restorations, chipped teeth, TMJ issues. So again, as you're doing your oral cancer screening and you're evaluating the TMJ jaw joints there, if you're noticing that there's clicking and popping, looking for those things. Headaches, migraines as well. So other clues to look out for are, the mouth breathing that we kind of talked about, allergies. So again, like the 3 Ds, very common with mouth breathing, dust, dairy, and dander. Do they have former or current sucking habits like thumb, fingers, sleep apnea, snoring, and picky eating habits as well. So, again, those texture issues. Maybe they're drinking liquids frequently between meals, drooling past the age of 2, digestive issues. So very common, acid reflux, GERD. Really be on the lookout for that as well when you're cleaning someone's teeth, because it is a common GI problem in the United States that is linked to sleep breathing disorders. Belching, bloating, hiccups, gassiness. Again, that is from swallowing too much air. History of ear infections, as I talked about earlier, is that we're swallowing up and back like that wave, we're able to clear the eustachian tubes. Then history of orthodontic treatment, relapse, lingual restrictions, and then of course speech impediments. So what are some tips that you can develop a myo-healthy child? So we want to breastfeed as long as possible. When we're breastfeeding, it's using more muscles than bottle feeding. when a child is breastfed, they're actually pressing the breast up and to the palate, and it's spreading the maxilla. So again, it's that palatal expander that we're trying to achieve. Avoiding pacifiers, sippy cups as well. We want to follow baby-led weaning, weaning with solid foods. A lot of kids, I feel like nowadays, are given the pouches, the softer foods. Encouraging chewing harder foods. Chewing helps to stimulate jaw growth. In addition, and then teaching good chewing mechanics. So chewing slower, rotating that food side to side. We want to keep the lips closed with swallowing instead of open, which can cause swallowing of air. Poor mechanics of chewing could be rapid eating. The mouth is open, acid reflux, excessive belching, the tongue thrust. And then, of course, encourage the mouth to be closed. Teach nasal breathing. So as I talked about that one exercise, hand on chest and tummy, it's great with kids to lay them flat on the floor, put something on their belly and watching it rise and fall, teaching that nasal breathing and engaging in that diaphragmatic muscle. And then remember, medicines are band-aids. We really need to find the root cause, identifying if there's sleep concerns, treating with early orthopedic evaluation, and then of course an early myofunctional evaluation. So what does therapy look like exactly? So pretty much all new patients, they start with a consultation to really ensure that this is the right path for the patient. So data is collected to ensure an effective diagnosis is made. So that includes taking a CBCT scan just to make sure there's no obstacles in the way before starting therapy. There are a variety of treatment programs. So therapy is really tailored to what the patient needs. We have mini myo program, we have the functional frenuloplasty program. Some patients who have sleep apnea need certain things. Boteco, the functional breathing, we incorporate it as well. And then there is a comprehensive program that could run up to 22 months. Average is about 12 months, and we see the patient once a month. But really, it truly depends on what the patient needs. Therapy is really tailored to each individual person. Children as young as 3 to 4 years of age, teens, adults, and seniors can benefit from treatment. Each session is really preparing the patient for the next session. So it's kind of like I describe it as building blocks onto the next. It's a series of exercises that are given to really retrain and strengthen the patient's facial muscles. The various exercises really focus in on breathing, nutritional counseling, tongue posture, lip posture, correct swallowing, chewing, and habituation exercises. So in addition, we use intraoral functional appliances, which are known as MyoBrace. So they really help to unlock natural growth and development. Treatment for that is really best suited from like 3 to 15, but we also do use it for adults as well. So this for me is really just a tool that I use in conjunction with therapy. It is worn 1 to 2 hours a day and every night. I don't just rely on that because I do feel exercises are key as well. And then, of course, home participation and compliance is key. I mean, I could teach people exercises all day long, but really going home and practicing them and putting the time in is how you're going to see the results as well. So I want to show this intro here. This is the intro to MyoBrace. It's a video that I show when I do my consultations as well. So I'm going to show this here.
Hi there, my name is Andrea.
And I'm Ben.
And today we're going to learn about some fun ways to help you get straight teeth and grow your jaws.
We now know that when we start to see signs of crooked teeth, it usually means the jaws aren't growing properly. Bad oral habits, like not swallowing the right way and breathing through your mouth, are the main causes of the crooked teeth and jaws. The forces of the tongue, cheeks, and lips combined with these bad oral habits can have a big effect on how your teeth are positioned, as well as how your jaws grow. A normal top jaw grows properly because the tongue rests in the correct position, which is in the roof of your mouth, known as the correct tongue resting position. If your tongue does not rest in the roof of your mouth, the top jaw will become too narrow, so teeth won't have enough room to grow straight.
Another thing to watch out for is if you're swallowing the wrong way, with lots of movement in the bottom lip. When this happens, your front teeth will be pushed backwards, and this also causes your teeth to be crowded. Your MyoBrace, as well as the MyoBrace activities we're going to talk about, will help you fix those bad habits so your teeth and jaws can grow the right way. If you have a look at this boy, you can see what happens when we change from an incorrect tongue position to the correct tongue position. Once those bad habits have been changed, you can notice the difference straight away. So, how does your MyoBrace work? The MyoBrace appliances work by teaching your tongue to rest in the correct tongue resting position. Breathe through your nose normally and swallow the right way.
MyoBrace activities help this by stretching, strengthening, and retraining your tongue, lip, and cheek muscles, as well as improving the way you breathe. If you can control where your tongue is positioned and the way you breathe, then your treatment time will be shorter. Your teeth will naturally become straighter, and your jaws will develop the right way.
The MyoBrace is a very important part of your treatment, and it needs to be worn every day for 1 to 2 hours and overnight while you're asleep. You can wear it while you're getting ready for school, doing homework,
Playing games, or even while you're watching TV. It can't straighten your teeth all by itself, though, so it's important we help the MyoBrace do its job by completing certain tongue, mouth, and breathing activities. If you're wearing your MyoBrace as well as completing the MyoBrace activities every single day, you'll be on the fast track to making your teeth and jaws grow correctly. If you want your teeth to be straighter and your jaws to grow the right way, you need to be prepared to put in the effort and do your MyoBrace activities every day. Remember, those bad habits didn't appear overnight, so it may take time to train new ones.
By working hard and altering bad oral habits, you will get great results. But it's up to you to make the change. If you want to know more, you can talk to your MyoBrace educator or check out myobrace.com.
All right. So I just want to end it off with, I love this quote, keep it up your tongue, that is. And I want to thank everyone for coming on and listening. And I'm going to have Dr. Robinson kind of come back in and help me if we have some questions here. I know he wanted to talk about something else as well.
Hey, Lauren, great job. I'm here. Let me just turn my video back on. Yeah, awesome. Can you see me?
Yeah, I can see you.
All right, great. So thank you so much. That was amazing. And so I think we do have a couple of questions. And if anybody has any questions that they can think of right now, if you could please just chat them in the Q&A box. Lauren and I will work with getting all these things answered. So I answered a couple of questions for you, Lauren, during the presentation. Reverse swallow is what's called is another name for a tongue thrust.
Yeah.
And then somebody asked about the difference between ADHD and sleep disordered breathing, and how you can do that as a dentist in the office. And so my recommendation was to screen for a sleep disorder before you automatically jump to the diagnosis of ADHD, because ultimately ADHD is a pretty severe diagnosis. It's a pretty serious diagnosis that has a lot of pharmaceutical ramifications. And so I always would suggest, making sure you get all the data collected and make sure you do the proper screenings first, evaluate a child's sleep, evaluate a child's breathing before you automatically jump to a diagnosis. In our clinic, what we do is we take a lot of facts. No patient walks in with a diagnosis from us already. We don't make a diagnosis until we have all the facts. So I basically said, you can do some sleep screening forms, chairside. You can do a little intraoral evaluation and breathing evaluation chairside, like you've just taught everybody how to do. And then if there's any suspicion whatsoever, any red flags, refer that child to a sleep specialist, like Lauren or like myself, or even like an ENT in your area who might specialize in this type of thing, or even maybe send them to, a pediatric pulmonologist in order to get a sleep study if you have relationships like that. Lauren, would you add anything else to that?
No, I think that was perfect.
Okay. All right. Some questions are really pouring in here. So how does a low tongue create a deep bite?
Oh, how does like the low resting tongue posture of that?
Yeah, how does that create a deep bite?
Yeah, well, of course, I mean, everything, like we want that tongue up because it's going to create the width of those jaws to expand upward. So obviously someone that has a deep bite has that lower jaw. Um, the lower jaw is not the width that we obviously want it to be. It's insufficient and gross. So obviously the tongue, I mean, crucial with all OMDs is that we want that tongue up, that correct resting posture. So it is common, not with all deep bites, but it is common to see more of a low resting tongue posture with that deep bite. And then as I mentioned before, like habits like nail biting, clenching and grinding can also deepen the bite as well. So there could be many contributing factors to that with a deep bite.
Yeah, and let me add on to that just for a
I
second
mean,
because
I don't know if you could answer that.
yeah. So I mean, like Lauren has taught us, our genes tell our bones to grow, but our muscles tell our bones where to grow. And the teeth are part of the bony housing. And so what I found with a lot of my patients that are walking in with sleep and TMJ dysfunction, they do have an OMD. They have a myofunctional disorder. And a lot of them have very tight orbicularis oris. A lot of them have very tight mentalis. So if you think, right, Lauren, if it's a bunch mentalis, if it's a very tight orbicularis oris, that's going to create more of that deep bite that we're talking about because the lip muscle is actually pushing on the front teeth, preventing the outgrowth of the jaws and creating the deep bite that we're seeing. So that's one way that we see it. The other thing that I would challenge you to think about is where is the tongue positioned and where is the tongue resting throughout the majority of the day and throughout the majority of the night. A lot of our patients, again, have tongues that don't fit in their jaws because of lack of development. So a lot of our patients' tongues sit on their posterior teeth, right? So things will keep moving until they touch. So if the tongue is keeping the back teeth kind of in the correct position and the front teeth are still moving, you can get that deep bite as well. Lauren, would you agree with that assessment?
Yep.
Okay. Hopefully that answered that, Ashley. So Lauren, can you describe the 3 Ds you mentioned about allergies again? Dust.
Yeah, dust, dairy, dander. Usually
Dust,
are
dairy, dander.
common with mouth breathers. So really, to kind of elaborate on that, I would say too with like the dander is, many kids too are living maybe with pets. Not that you can get rid of your pets, but they may have an allergy to that. Dairy is also another big offender too. We do know that can cause inflammation as well in the body for some people, and of course what causes inflammation for one person may not be for the other. It's the same with like gluten too, can cause inflammation in the body for some people as well. So but those are kind of the 3 main D's that I would say like with mouth breathing that is pretty common.
Yeah, another great question here, and I think it's one of the more important questions that I've seen so far. Do you incorporate myo exercises with myo brace? And the answer is a resounding yes, 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 yes. Do not give a kid a tool that they don't know how to play, that they don't know how to work with. So I can't emphasize enough how important it is to do exercises with myo brace. I kind of went over that on my last lecture last week or 2 weeks ago when I went over pediatric sleep-related breathing disorders. But without myo exercises, the myo brace is not going to be anywhere near as effective. It's kind of like giving a kid an instrument and telling them to go play it. No, they need the proper coach. You need a coach to be able to teach you how to play an instrument. So Lauren, if you want to.
Yeah, and I mean, I think there was a question on there too about asking about with significant overjet and myo brace. So, I mean, again, I think with the myo brace, it really is tailored to each person and what they need. I would say not all of my patients I give a myo brace to. So it really depends on that patient, what they need. We don't really give it out to everyone. We use it as just a tool in conjunction with the therapy.
Yep. Can't agree more. So somebody said, can myo brace be provided to patients by general dentists or only by orthodontists? No, anybody with a dental license can provide myo braces to their patients. But again, just remember, if you're going to give your patients functional appliances, you better be prepared to manage them and have a myofunctional therapist, in my opinion, or a dentist trained in myofunctional therapy, or a speech language pathologist trained in myofunctional therapy to kind of manage the care with that. Hope that helps. So I'm going to go to the next one, Lauren. What is the proper order of referrals for the patient as far as who they see first? Pediatric, general dentist, an ENT, an OMT, a speech pathologist, etc. So let me answer. Jessica has a couple questions. So let me answer that question. Let me answer the first question. So in my opinion, you have to look at who's around you and what they're capable of doing. In our area, we're kind of one of the only ones who can be the triage of care here. So anybody with a suspected problem in our area can send them right to my center, pain and sleep center, and we'll work the patient up and then get them off to the right referrals. And even more important, and Lauren, I want you to touch on this because, Lauren had someone who's very close to her just visit one of our local ENTs. And, the ENT just wasn't prepared to answer any questions, didn't know the history, and the mom just didn't have the tools in order to be the child's advocate. So you have to really look at who's around you in your area, send them to the person who's going to be able to do a comprehensive evaluation, get some diagnostic things completed, and then kind of outline the steps. So for us in Delaware, in the Philadelphia area, that's us at the Pain and Sleep Center. But in your area, I would highly encourage you to look into who can provide these types of services like Lauren and I can. And then, do allergies have to be under control prior to OMT for nasal breathing to be effective? Allergies do not have to be under control, and that's one of the main things that Lauren will work with is getting the allergies under control. So Lauren, do you want to elaborate on that a little bit more?
Yeah, we definitely, of course, like whenever we're doing our consultations, we always want to find the root cause. So a lot of times, we are involving many healthcare providers, and truly each case is really geared to what that patient needs. But yeah, with allergies, definitely for us, we do incorporate like nasal sprays like X-Clear. We do use a lot here in the practice. It is a natural nasal spray that has saline and xylitol in it. Flonase, Sensimus will recommend as well. So I feel like definitely incorporating that as well too before a patient even sees an ENT too, I think is great, because if they've already been using that, a lot of ENTs, especially if they see a kid who has enlarged adenoids, they may say, oh, let's just try a couple months of doing some nasal sprays. But a lot of our patients are already going into that process, already trying that. I don't know if that kind of answered some of that, but.
Yeah, for sure. So Jessica also asked, are there any dental codes we can use for these evaluations at the hygiene appointment or at the comprehensive exam? Lauren, you can use a comprehensive oral evaluation dental code for these types of things if you want some reimbursement through
Yeah, you can.
insurance.
That's what we did, right?
Yeah. And then for the comprehensive examination, there are codes that you can use through medical, but I'm not aware of any comprehensive myofunctional assessment codes that are available through dental. These insurance companies are just way behind, and they're not going to reimburse a lot of this because insurance is not preventative. Insurance is reactive, so they would rather wait to something to happen and then pay for it than to pay for preventative service like Lauren and I bring. So unfortunately, insurance companies just have not caught up with this yet. So I hope that answers that question. So Joe asked, with the MyoBrace, are you worried about the retractive forces on the upper incisors if the patient has a significant overjet? Lauren, you want to answer that?
Yeah, I think that's what I kind of talked about, that it truly does depend on, the MyoBrace might not be something that's beneficial for everyone. So, I know that the one CBCT scan that I put up was of a patient that you could see he had significant overjet. So we do need to get, an orthodontist in the mix to really help with the expansion of his palate. So, it really does therapy kind of for each patient. It depends on what that patient needs. The MyoBrace may not be the best treatment at that time for that patient. We may need to get an orthodontist. We work with Dr. Evans, who is an airway orthodontist, on board as well into this process.
And then are MyoBrace and trainer appliances the same in the mechanism? So MyoBrace versus trainer appliances.
What do you mean?
Yeah, so the MyoBrace versus the trainer appliances. So there's a lot of trainer appliances that are out there. I would say the,
I think they are the same.
yeah, the mechanisms of them, or some of the trainer appliances are as simple as, you know, training lip seal, or, you know, training tongue positioning, and other MyoBrace type functional appliances are actually, you know, full kind of appliances that go in the mouth and stay there. So the mechanisms are different in just about all of them. Even the mechanisms are different in the different MyoBrace series of appliances that we use, Lauren, right? I mean, there's the mechanisms, I would say, are they're different in every appliance.
Yeah, they really are. I mean, I think that you answered that good.
Yeah. So how often do you meet with patients? Somebody wants to know.
Yeah,
For you.
I mean, typically it is once a month that I meet with the patient. So, and the visit is, you know, roughly 45 minutes to an hour, I would say, but once a month.
Yeah. Okay. And then somebody asked about our range of fees. So, I mean, just to give you a ballpark, I mean, you're either going to, if you're going to start treating, if you're going to get the education and start treating, you know, myofunctional therapy in your office, you really have to figure out what fees work for you. Lauren puts a lot of time into what she does. She's highly educated. She's very much so in line to give the patient a whole lot more than just a piece of plastic to go home with, to train with. So our fees kind of represent that. But I would say you can go from anywhere from an hourly fee of $100 an hour to anywhere of selling a package up to $4,000, $5,000, $6,000 if you're going to go through orthodontics and all that with a myofunctional therapist, with expanders and things like that. Let's see what else. I'm an RDH com and on track for QOM, and this was precise and very well done. Thank you for sharing. What type of tongue exercises do you recommend while wearing the MyoBrace? Man, there's a ton of them, Lauren. Do you want to? I mean, there's
like way too many to go over all those.
yeah, Lauren's got a manual that's about this big that she literally will just take out each sheet and kind of train the patient and give them the exercises that she think would benefit from that. So it's not necessarily the exercises that go in conjunction with the MyoBrace. It's the exercises that go in conjunction with the therapy and the results that Lauren is trying to achieve with her patients. It seems that there may be a possibility of root compromise with the MyoBrace. Is there a fear of interference with root formation during MyoBrace? I'll answer that as a dentist who did orthodontics for a long time. There's a much, much less chance of root compromise with a MyoBrace than there is with actual conventional orthodontics. You have to remember, when the muscles are pushing on the teeth and pushing on the bones, you know, everything is moving together. So unlike where an orthodontist will grab a tooth and move the tooth and then let the bone catch up, with the MyoBrace, you're really trying to keep the muscles away from the teeth. You're trying to put pressure on the MyoBrace with the tongue up to the roof of the mouth. You're trying to get the lips to stay off of the teeth. So we find that although not as great of development, although not as great as tooth movement quickly with MyoBrace than conventional orthodontics, you'll never see root resorption or root compromise with a MyoBrace, just because it's such a slow, you know, kind of whole facial, craniofacial kind of movement of the jaws instead of just tipping teeth and moving teeth around. Would you agree, Lauren?
Yep.
Okay. So can you describe MyoBrace function, how often patients need to use? What are you looking for when they come in monthly? When do they stop? What is the endpoint? That's a loaded question, Lauren. Do you want to try and take on some of that or what?
Well, I mean, basically, MyoBrace is correcting any like poor oral habits. So it expands like upper arch form and exerts like light forces to align the teeth and jaws. So it really is, like I said, it's used in conjunction, and there are different stages of the MyoBrace. Like the first stage is really habit elimination. Second stage we use is arch development. Third stage is dental alignment, and then the fourth stage is retention. So I would say every couple months I'm like transitioning patient through those stages. They are to wear them for at least 1 to 2 hours during the day, and then every single night. And then of course, if they're not consistent with wearing them at night, we increase day wear as well. I don't know, is there anything else like you could kind of add on to that, Dr. Robinson, that I?
No, I think that's good. Jonathan, you have our email.
Definitely email us too.
Yeah,
If you have questions, if you want
contact
to
us on
go
the
a
side, and
little further.
we'll go over some of that stuff. It's just such a lengthy question. Do you offer virtual treatment? Yeah, Lauren's been doing a ton of this stuff virtual. Do you want to talk about that, Lauren, real quick?
Yeah, I mean, I would say like a lot of my patients that, I mean, well, especially recently too, with everything going on, all of my appointments have been virtual for the last several months. So yes, I do offer virtual.
And I've not done this, but maybe you have, Lauren. Have you treated any patients with a connective tissue disorder? If so, did you find it worked well for them?
No,
Myofunctional
I have not now.
Okay. Yeah. Sorry, Mary Rose. I have not seen that. And then you're going to go back to the.
Yeah, I see that. I'll go back to that slide.
Yep. Taking you back to the slide on tongue spot and finding the spot. All right. So Jackie says, for kids that have a bite plane after phase 1 ortho, do you have any issues with the palate collapsing when using the myobrace instead of the bite plane they are provided? Does the myobrace retain the palate like the bite plane would? Or do orthodontists you work with have an issue with the kids using the myobrace instead of the bite plane at nighttime? Lauren, do you want to touch on kind of retention and that type of thing? I would say this: if you get a collapse of the palate after phase 1 ortho and patients in active myotherapy, I mean, the therapy is not working even a little bit, because the whole point of myotherapy is to brace the palate and support it in its new structure and to keep it that way. So if we have a collapse, we are having very poor therapy. Would you agree, Lauren? What would you say
And I
about
mean,
that?
like the tongue up, obviously it's stabilizing the jaw. So, I mean, that if we're working on therapy with that, that tongue should be up and stabilizing it. So you shouldn't really see a collapse of that. If anything, we should see more of that expansion of that if we're getting that tongue up than of collapse. And I guess to answer the question with the myobrace, what was the question? It says, does it retain the palate? So, I mean, I would say like with the myobrace, you know, there is a position in the myobrace that kind of helps to keep the tongue resting at the roof of the mouth. There's like little buttons on the kind of like what helps deactivate overactive lip muscles, keeping the tongue up and establishing nasal breathing. So, and then of course, one thing to note on that is that, you know, if the child is also mouth breathing at nighttime, you know, like we need the tongue to be up to stimulate the growth of the jaw that happens while we're sleeping at night. So, you know, is mouth breathing happening while they're sleeping at night? So that tongue isn't really stimulating the jaw growth. That's something too, I guess.
Yeah, no, I would agree. And what you'll find is that if you are doing good myofunctional therapy, I mean, your orthodontist will become your best friends, because when they do phase 1 expansion, and typically they have to rely on, you know, luck, stabilization, bite planes like you're talking about, retainers, things like that. Instead of using appliances to hold the new position, you're just using the muscles now. So if you're doing good myofunctional therapy, you're using the body in order to hold the position that you just gained. So orthodontists should learn to love all of you myofunctional therapists out there, because you make them look good. I mean, you make their work not come back and bite them in the butt. Okay, do you incorporate orthodontics, interventional, and fixed in conjunction with your myofunctional treatments? Absolutely. So we do work with a couple airway orthodontists here in our area, and we do phase 1 orthodontics at Pain and Sleep Therapy Center. You know, we do ALF and some bonded expanders and some functional appliance and things like that. So yeah, we do use orthodontics, interventional and fixed within the practice. Actually, my son is he's 4, he's going to get his ALF in the next few months. So we're really excited about that. And Lauren's been working obviously with my kids with myofunctional therapy for a while. So a lot of people asking how do they get trained, myotherapy training. Hopefully you saw Lauren's slides on where she's been. MyoBrace, the company MyoBrace, they do a really good job of giving people a lot of education, and I would say that's a really good resource. The IAOM is another good resource. The AAOM is another great resource. There's a lot of people that are popping up out there. Who knows, maybe in a year, Lauren will have her own teaching educational program. But there's a lot of places to get myotherapy trained. Just type it in myofunctional therapy training and you'll find some really good ones out there. So how do you find a team of specialists to help the patient out? Man, that is such a good question. It's really hard because, you know, so many of these specialized providers are just very hard to find. And that's, you know, why we are proud of what we've been able to accomplish and bring so many people under one roof and work with the absolute best specialists in our area. So really, how do you establish and find a team? You got to go out there and look for them. You got to use the Dr. Google. You have to go on the web and find out who's around you. You have to pick up the phone and call. You have to ask them leading questions like, what is your philosophy on this? Have you worked with myofunctional therapy? How do you triage a child who has suspected signs of sleep disorder breathing? I mean, you just have to interview your local people. And this took us years. We've been working on our local community here for many years before we were finally established and, you know, could make our mark here in Delaware. So you just got to work hard. Okay. Do you have any suggestions for getting ENTs and dentists on board with myofunctional therapy and addressing the airways? Yeah, case presentations, little drop-ins, like have one of your marketing people just drop off a folder and show them a case study. You know, call them on the phone. Say, you know, hey, Dr. Smith, ENT, right down the street from me. You know, I have Johnny here, and here's what he's presenting with. You know, what would you recommend? And then we always just have to you have to kind of be toe the line, so to speak, and be very respectful of what have been taught and what their current philosophies are. And you'll find the ones that are open to talking. You'll find the ones that are available to learn more. And then once you start treating cases in your office and you have success, you know, tell those moms and dads to shout it from the rooftop. Tell those parents that you've treated to go tell their friends and family. And believe me, this is how our frenectomy program got started. Now we have pediatricians that are literally referring frenectomies to us because they've just seen so many of our patients walk in their door and say, Dr. Robinson, Dr. Green, Lauren, they treated me, my life changed, you know, blah, blah, blah. So just make sure you're doing really good documentation of your cases and being able to have good conversations with people who might otherwise have different education and training than you and may not be up to speed with all this kind of newer stuff that's going on. What courses do you recommend taking? I think we just went over this. I'm an orofacial myologist. I'm just starting out. Great for you, Joanne. That's awesome. It's really neat to see so many orofacial myologists popping up, whether you're an SLP, a dentist, or a hygienist. I mean, just take as many courses as possible. That's what I would say. Lauren and I have really, truly built our program around the influence of many of our mentors, whether that be an individual out in South Bend, Indiana, in Dr. Clower's office, whether that be, you know, across the coast to the other side of the coast on the West Coast with the Breathe Institute, and whether it be Sandra Holtzman. I mean, just take in as much information as possible and put together, you know, a program that you believe in and that you think is beneficial for you and your workflow. And it'll probably take you a long time to get there. This isn't easy. This isn't like going and learning how to place an implant. CE, got that. Okay. Oh, Becky's here. Don't forget Sandra and I at Neo Health Services. That's right, Becky. Thank you so much. Yes, Becky Ellsworth and Sandra Holtzman. Like I said, we got basically all of our foundation and all of our training, the core principles from these guys, and that is with Neo Health Services. And they teach courses all over the world. Do you have a link, Becky? Do you have a link that you could share on the chat here? Anyway, yeah. So I think we're good. I think we're good. If actually, Lauren, can I take back a screen share real quick?
Oh yeah, go ahead. I think there's one question too. I did want to answer that I saw, and it said something about if the tongue is on the spot, should the teeth be together or separated. So it should be what we call freeway space. So there, it should be separated. When that tongue, that tip to tail is up, you should have slightly parted teeth. They should not be clenching down. Or touching.
Yes, thank you so much, Becky. The I'm going to type it in for all the panelists, for all the attendees here. It's oralfacialmyology.com. Sandra and Becky are the absolute best. Yeah, and then Lauren, can you make me host again?
Oh yeah.
Can you click on me and then go to the three dots and go to make me host?
Mm-hmm.
So just hover over me
Mm-hmm.
and then click on the three dots and go to make me host.
Yep, got you.
Yeah. All right. So just to kind of end things here, just wanted to share with you, my personal experience with myofunctional therapy and my kids here. So this is my daughter Reese and my son Bryce, and they're in here with Lauren, learning some breathing techniques and kind of messing around. And then here's my son Bryce in for his evaluation for his ALF.
What is your name?
Bryce Nolan Robinson.
And how old are you?
4.
Good.
So there's my little guy saying his name, and we take videos in the office all the time.
And what is this?
A robot.
Good. Okay. So what color is this?
Red.
And what is this?
A robot.
Good. And how about this?
Sun.
And let's see, what other one do we pick on here? This one. What is that?
Stinky socks.
Stinky sock. Okay, we'll go with that. And how about
that?
And this one?
So Lauren, I'll just stop because I'm not going to take up too much time, but you can kind of go over just a little bit of like, what you're doing with all this. I mean, you have them say their name, you have them pronunciations, you have them do a drinking evaluation to look at all the muscle function here, right? You have them do an eating evaluation, so we have a lot of fun with the kids in the office. And he's being goofy here. There we go. So Lauren, do you want to just comment on that?
Yeah, so I mean, obviously, like we'll do the drinking evaluation to check like how their swallow is. And then of course, like while they're eating, like checking to see like how they're chewing. Like, are they a slow eater? Are they fast? Is their mouth opening? I know with Bryce, he did a lot of open mouth, which a lot of parents will kind of think that is like poor manners. A lot of times that's just because they can't breathe out of their nose. So we're just checking like the chewing mechanics, like what's happening as they're chewing, making sure they're kind of rotating that food to side to side. They might need to drink many liquids in between, or they're packing it in their cheeks. So just really kind of evaluating their swallowing, their chewing mechanics, and just seeing how they typically, what they're doing on a daily basis when they're eating and drinking. That gives us a good indication for obviously what are things that we need to work on in therapy.
Yeah, no, thank you. And then just to kind of conclude, I mean, we get this question all the time, like how early do you start? And like, there's never too early of an age to start, with simple things that you can incorporate, and having your kid being evaluated by a person like Lauren. And, things change. So if your kid was evaluated when they're 2, you can bring them back in at 4. I mean, we're here for you. And a lot of my functional therapists are like that. And it is like an ongoing sort of therapy that happens throughout the greater parts of the peak development and growth and development. So here's a couple pictures of my kids when they were younger. And this is a more recent picture of my son Bryce on the right side there with his mouth taped shut at nighttime, making sure that all the air goes in through his nose, just like Lauren was talking about. And of course, his little stuffed animal, Grinchy, tapes his mouth shut at nighttime too. So I think we've exhausted our time here, right about 2:30, Lauren. So I want to thank you again for such a wonderful presentation. I want to thank everybody who attended today, and we will see you back next week for the cardiovascular presentation on Tuesday, the exercise to relieve stress on Thursday, and then the following week we have Dr. Joanna Green and myself and Lauren going over tongue ties, and Lauren will end with Buteyko breathing and the power of proper breathing. So thanks, guys, and we will see you all next week. All right, take care.